In October of 2015, I was invited to speak at the Airline Pilots Association's Critical Incident Response Chairs meeting that took place at the United Airlines headquarters in Denver, Colorado. In the months that have followed, I've been asked several times if a recording of this talk is available, to which my answer has unfortunately been no. So I've decided to make a recording of this talk along with the associated PowerPoint presentation that I gave for those that are interested. The title of this talk is Safeguarding a Pilot's Mental Health. In addition to working as a pilot for SkyWest Airlines, I'm also a licensed clinical mental health counselor, professionally licensed in the states of Colorado and Wisconsin, and I maintain a clinical practice in Denver where I have specialized in working with flight crew. The reason I maintain licensure in Wisconsin is because I co-run a publicly funded fear of flying treatment program out of Milwaukee General Mitchell International Airport with the program's founder, Dr. Michael Tamaro, who is a clinical psychologist and flight instructor that started the program 26 years ago. This program is the longest running and only publicly funded fear of flying treatment program in the world, and I began working with Mike and his program while completing graduate studies at the University of Wisconsin-Madison. Mike served as a mentor and one of my clinical supervisors while I was completing my graduate work in counseling and clinical psychology. This program is where I began my work in the field of clinical aerospace psychology. Through my work in this program, I was initially surprised by the number of commercial airline pilots and flight attendants that were seeking treatment for a fear of flying. Through the process of working with these individuals in both individual and group contexts, I quickly realized that effectively working with and treating professional pilots, and particularly commercial Part 121 airline pilots, was incredibly specialized, required an approach that was unlike treating any other population I'd worked with. Although the field of clinical aerospace psychology has vast amounts of published literature on assessment and diagnostic techniques, all very important and relevant aspects of working with pilots, there is little guidance and perspective on how best to actually treat this group once all the testing is complete and you have them in your office. When Louise Cullinan, the Critical Incident Response National Chair for ALPA, first asked me to speak at this meeting, I struggled with deciding what would be the most useful and informative topic that I could talk about, especially speaking to a group that undoubtedly had a pretty keen awareness, knowledge, and appreciation for the negative effects that can happen to flight crew following a critical incident. One of the most common questions I'm asked from fellow pilots and CIRP volunteers, other than the, so I have a friend kind of problem questions, is one, why do pilots contact you and not our EAP? Two, what are the issues that pilots come in to talk about? The third most common question is, how do you work with pilots? And lastly, doesn't our EAP already do that? So within this presentation, I thought I would briefly try to describe and answer those questions from my perspective as a commercial Part 121 air carrier pilot that flies about 800 hours a year, and as an independent psychotherapist and mental health professional that maintains a clinical practice about 3 to 5 days a week, working exclusively with pilots, a group that I personally consider to be one of the most dynamic, complex, very intelligent, often unrelentingly stubborn, and resilient groups of individuals that I'm lucky enough to consider myself to be a part of, something that I'm very proud of. So, reasons pilots end up being referred to me. Now, one of the most common reasons that pilots contact me is because they reached their limit of EAP sessions. And as most EAPs utilize a brief short-term model, and pilots are so reluctant to seek psychological services in the first place, and I'll speak more about this later, the issues that would initially bring a pilot to the EAP are often not something that is likely to be solved in the 2 to 5 sessions that is usually the EAP limit. Now, once the session limit is reached, and unless that EAP counselor is an authorized provider on the pilot's health insurance plan, which they often are not, the counselor is forced to terminate the relationship and refer the pilot to another provider. Now, this can present a tremendous dilemma for that pilot because if perhaps they did work well with that counselor, the termination of their therapeutic relationship can be disruptive and even in some cases incredibly damaging to that pilot. Pilots are often very distrustful of medical professionals, and this forced termination of sessions from the EAP provider can exacerbate these perceptions, making them less likely to seek further treatment with a new provider, as the thought of having to, start over with a new MHP or mental health professional seems just too daunting. So once the EAP sessions end, most often the counselor makes a recommendation to the pilot to continue services with an MHP that accepts their insurance. I cannot even begin to tell you how many pilots balk at the idea of seeking services where their insurance will be billed. Now, part of this is out of the pilot's own ignorance of how the medical system operates and communicates, and part of this is because pilots have paid an incredible price in the past for receiving psychological services through their insurance providers, and this became known, either voluntarily or involuntarily, to their aviation medical examiner, or AME, and then subsequently to the FAA. And, news of these unfortunate incidents that happened to pilots and their medicals spread throughout the pilot community like wildfire. Once pilots believe that a paper trail will be created should they seek services where their insurance is billed, fearing that it will lead back to their employer and to the FAA through their FAA medical examiner at their next flight physical. As medical records continue to be converted to a digital format, the speed and accessibility at which these records are made available to providers is astounding. Currently, the FAA does not access pilot electronic medical records, in large part because of the current HIPAA laws, making only what the pilot voluntarily discloses during their flight physical known to the FAA. But beware, there is an undercurrent for a call to make these records available to the FAA, especially in light of recent tragic and near-tragic events that have occurred over the last few years where a pilot's mental health has been called into question. Now, unfortunately, the public's outcry for politicians and their various regulatory agencies to just do something following tragic or near-tragic events has resulted in non-scientific, illogical, and often damaging edict, as demonstrated by, for example, the TSA's confiscation of tweezers and other non-life-threatening articles following the events of 9/11, the 1,500-hour rule following Colgan 3407 accident, the sleep apnea upheaval following the GO Flight 1002 incident, the ban on all electronic devices on the flight deck after Northwest Flight 188, and countless other events. Fortunately, zero regulatory fallout has resulted from the JetBlue Flight 191 incident that occurred back in March of 2012. Do you remember that one? Where really this highlights the significance that public perception has, as this event had a fortunate outcome with a somewhat heroic quality, as passengers were able to restrain the ill captain while the first officer safely landed the plane. Or maybe this event highlights a lack of understanding and direction as how to most effectively safeguard a pilot's mental health while protecting the flying public. The common thread that all these events have is that in the end, it is the professional pilots whom, to no fault of their own, are forced to carry the legacy of these events through punitive, burdensome, and often altogether ineffective regulatory changes. And pilots know this very well. I've found this perception among pilots is common and largely contributes to their avoidance of insurance providers. But perhaps the biggest issue that pilots face when seeking mental health services that are underwritten by insurance providers, and this is often unbeknownst to many pilots, is the issue of reimbursement to the mental health care provider. The overwhelming majority of insurance underwriters will not reimburse mental health professionals for their services without a diagnostic code, that is, a diagnosis to justify treatment. To the general population, a diagnostic code has little, if any, impact on their life. In fact, the code works in their favor as it grants them the treatment that they need. But for the pilot, the majority of mental health diagnoses, and often the most commonly utilized ones that MHPs utilize to ensure reimbursement, will ground the pilot, sometimes permanently, should this become known to the AME or the FAA. Pilots and MHPs are put in a very difficult bind. So, to the savviest pilot, they choose to seek counseling or, treatment, mental health treatment, out of pocket from an independent provider that doesn't need to submit paperwork to their insurance provider. I've found that pilots really actually want to tell the truth, even on their medical, and by paying out of pocket for services where no diagnosis is given, makes it somehow more justifiable in their mind to not report it. Once there's a paper trail, even though the FAA does not have access to it, believe it or not, pilots want to self-disclose. Part of our culture as professional pilots is to self-disclose in exchange for protection. Unfortunately, protection doesn't work that way when it comes to your medical. A checked box under any of the psychiatric conditions on your medical will result in an automatic deferral to Oklahoma City. This can't help make one think that the only reason a working pilot would check that box is if they were naive. Second reason pilots come to me is for a CIRP or a Pro Standards referral. This can occur at any stage within the CIRP paradigm, but typically this occurs within the diffusing stage if those participating in that know about me, or the debriefing stage if the MHP that is present during the debriefing makes the referral. From the Pro Standards side, the only time I'm contacted is when they usually don't know what else to do and the pilot is on the verge of being terminated. Please, for those that work in Pro Standards, don't let it get to that point. If something doesn't seem right, contact me or another MHP early. Another reason pilots come to me is they may have had a bad therapy experience from their employee assistance program or their EAP. This is just a common issue in therapy across all populations and demographics, and not just exclusive to EAPs. However, many of the pilots and flight attendants I work with have been through the EAP process, so this is just my experience within my practice. A therapeutic relationship takes time to develop, and sometimes it just doesn't click. Some of the most common issues I've gotten from pilots and flight attendants with regards to past therapy experiences are, I didn't have very many sessions, so I felt like it was going to be just a big waste of time. As stated earlier, EAPs often have a 3 to 5 session limit, which in the world of counseling is not very much. 2, the therapist just doesn't understand this industry. I felt like I had to explain everything over and over to them. Now, aside from medicine, I don't know of any other industry that has as many acronyms as aviation does. Working as a pilot or flight attendant is as much a lifestyle as it is a profession, simply because it displaces us from home. Unless it's a go-home day, ending your workday on a trip does not mean going home to your family. It means going to the hotel with your work family, which entails social dynamics with your crew, challenges of living out of a hotel, and living out of your rollerboard. These acronyms are as relevant to your job functions as they are to the schedule you hold, the time you have at home, your time away from home, and your overall lifestyle on the road. The therapist hates flying on the airlines. We all know that the challenges that passengers face in today's chaotic marketplace of flying. Travel anxiety among passengers is at its highest. Unfortunately, this can creep its way into therapy sessions, often resulting in the therapist colluding with the pilot and flight attendant in their complaints. Although this may create some temporary understanding between the pilot or flight attendant and their therapist, it's actually short-lived, it's unhelpful, and it's damaging. I'm astounded at the number of therapists out there that try to work with people that have a fear of flying of phobic proportions, that are afraid to get on airplanes themselves. You should just get a different career. Now, you wouldn't believe the number of pilots that come into my office that have been advised this, sometimes in a single session with an MHP. Although the complaints that flight crew may have about their careers can be severe, The sacrifices that pilots and flight attendants have made for their careers, along with the sacrifices they make on a daily basis to maintain their careers, are huge. I can attest that for pilots, flying is as much a calling as it is a job, despite its many downsides. This calling and all its sacrifices can be very difficult to explain to somebody outside the profession. The suggestion to just find a new career without extreme, thorough understanding and consideration and exploration is incredibly untherapeutic, and it's quite often, I would say, very, very ignorant. It just wasn't helpful. Now, this is much due to the therapeutic orientation of the therapist, as it is the willingness of the client to participate. As I stated before, I've found that working with pilots is very specialized, and finding the most effective treatment method is as much art as it is science. It can be like trying to land an elephant on roller skates in a 50-knot crosswind on a snow-covered runway. I'll speak a little bit more about this shortly. Word of mouth from other pilots. This is by far the most prominent way that pilots find me. We're an incredibly small community, and word does travel fast. Although I do have a website that I initially developed for Fear of Flying clients, I do not do any advertising. Aside from hopefully being a good therapist, I think one of the most important attributes I have are the epaulets on my shoulders as a pilot. Just as the CIRP volunteers, pilots find tremendous comfort in the fact that I'm one of them, subject to the same aspect of this job that they are. The brotherhood and sisterhood among pilots is an undeniable bond, a bond that most often transcends the differences we have from one another, especially in times of crises. If there's a pilot or flight attendant in need, get to them, because that unspoken bond that connects us to one another as a community can provide more comfort and help than you would believe. It's incredibly powerful and something that I don't take for granted for a second. What are the issues that pilots come in to talk about? Well, for the most part, pilots come in for the same issues that everybody else in the general population come in for. Marital or partner problems, career issues, financial issues, sexual and gender identity concerns, alcohol and drug dependency issues, stress responses from critical incidents, a fear of flying that can suddenly develop for a pilot or flight attendant. And contrary to public belief, this is usually not triggered by a scary event that happened in the air. It's most often tied in with self-control or interpersonal control issues. Can be anxiety from too much responsibility, grief reactions to loss, sometimes from the loss of a loved one from even many, many years prior, and other types of phobias I'm presented with. I just recently treated a woman that was concussed while she slipped and fell on the ice while conducting a walk-around and developed a phobic response to ice. This pilot was bidding trips on the West Coast when she lived and based in the Midwest just to avoid walking on ice. So the whole gamut of issues is represented. Unfortunately, most of the clients I see have been experiencing these issues for quite some time before they decide to seek help, and they often come in when they are experiencing significant, if not even sometimes clinical levels of depression and anxiety. Not unlike the general population, the cumulative effect of stressors is what I end up seeing the most. There is one issue that pilots are presented with that sets them aside that I'm often presented with, which is their decision on whether or not to take medication, and particularly selective serotonin reuptake inhibitors, or SSRIs, for their depression or anxiety. Many pilots initially come in to see me to help them with that decision. Although most of the pilots I end up working with are able to work on their issues and resolve their symptomology through psychotherapy and coaching without the use of prescription medication, there are many that cannot. I spend an incredible amount of time educating pilots as to what these medications do, how they work, and most importantly, what they can expect from the FAA decision path regarding SSRIs should they choose to take these medications and disclose this to the FAA. For those of you that are not informed on this, here's a brief synopsis of the process. In 2010, the FAA decided to allow pilots the ability to take 4 of the most commonly prescribed SSRIs via a special issuance medical. Much like the alcohol treatment program for pilots pilots that wish to take SSRIs must work with a HIMSS designated AME. The pilot is required to be on a stable dose of one of the 4 approved SSRI treatments for a minimum of 12 months before a special issuance can be granted. Personally, I've never heard of a pilot approved in less than 22 months, but that's just my own experience. The pilot must be seen by a board-certified psychiatrist and must be addressed using a test called the COG Screen Aeromedical Edition by a board-certified neuropsychologist. The pilot must also submit a personal statement describing their history of mental health issues. This information is then deferred to the HIMSS AME by the HIMSS AME to the FAA for review and approval. Now, should the FAA grant a special issuance medical, if the pilot flies for a Part 121 carrier, they must get a letter every 3 months from airline management, which would be the chief pilot in most cases, attesting to the pilot's competence, crew interaction, and mood, as well as receive the COG Screen AE protocol every 12 months. If the pilot decides to change medications, change dosages, or comes off the medication, they must demonstrate stability or lack of side effects for a minimum of 6 months and must repeat the neurocognitive tests before they are eligible to reapply for regular issuance. All of this, mind you, is at the pilot's own personal expense. Most insurance providers, in fact, I can't think of one, will cover the neuropsych tests. So here are some of the issues I see with this. First, who can stop working for a minimum of a year because they want to take an SSRI? There isn't a disability underwriter that will provide you disability for depression other than for depression that requires electroconvulsive treatment and for the most profound cases of severe clinical depression. For the garden variety, I don't feel so good. I think I'd feel better with an SSRI. Oh, look, I do. They won't cover that. Pilots are left to the good graces of their company and their union to help defer some of these costs. Now, for a regional pilot like myself, I would actually probably make more money on public assistance. Second, although the FAA has selected 4 of the most common and effective SSRIs, there are literally dozens of SSRIs and the newer class of selective norepinephrine reuptake inhibitors, or SNRIs, that are not included in this group. What's surprising to me is that of the 4 compounds that are approved, there is no reason to believe that they are safer in regards to their side effects than any of the other SSRIs that are not included, as all SSRIs on paper are capable of having similar side effects. Third, the costs associated with the required testing, especially if more testing is required outside of the neurocog screen, are likely to be seen as prohibitive to many pilots. Neuropsychologists can charge up to $500 per hour for their services, and I've seen pilots pay in excess of $20,000 for psychometric testing services. Fourth, I'm not sure about you, but I stay out of my chief pilot's office. I'd be surprised if he even knew my name. I also question what qualifications a chief pilot has with regards to assessing mood, especially given the context that this assessment is intended for. What happens if the chief pilot decides, I just don't like you, or here's what I want you to do for me in exchange for a letter? Although this may seem unlikely, this is the bind that those with top secret clearances within the Department of Defense ran into. As soon as someone knows something that you want to have via secret, they can blackmail you. Incidentally, the DoD finally did away with a ban on SSRIs for those with top secret clearances because of this very issue. Lastly, this policy does not take into consideration the broad use of psychiatric medications to effectively treat non-psychiatric illnesses. For example, bupropion, a common antidepressant medication, is known to be very helpful in helping patients stop smoking. SSRI medications are prescribed for several health conditions, including premenstrual syndrome and irritable bowel syndrome. There are a plethora of other issues with this. For the non-aviation civilian world, These medications have revolutionized the management of psychiatric illnesses and returned many patients to pre-morbid levels of function. This is not to say that SSRIs are a fix for all, for anyone that's experiencing mild or even moderate levels of depression or anxiety. And there's ample evidence that medication, especially when combined with psychotherapy, yields significantly better outcomes than just taking, the magic pill. But for those of you that doubt their efficacy, claiming they are no more effective than a placebo, I encourage you to spend time on an inpatient psychiatric unit. Your thinking will change very quickly, I assure you. Rigid thinking and banning the use of these medications would somehow ensure aviation safety or prevent pilots from using the medications without oversight is rather naive and perpetuates the stigma of mental illness. Some experts assert that psychiatric medications in general are too risky, having the potential of turning people into dangerous individuals. This viewpoint ignores the reality that untreated mental illness may represent a much more serious risk to aviation and to aviation safety than the use of medications. Within the professional aviation environment, history has proven this to be the case multiple times over. Perhaps it might be helpful to look at analogy populations that share similarities to pilots. The best analogy available presently would be driving and drivers, since they both require similar skill sets to flying and pilots. In 2000, the U.S. National Transportation Safety Board issued a recommendation to the Department of Transportation for the development of a list of safe medications for use by drivers. In response to this recommendation, the National Highway Transportation Safety Administration convened an international panel of scientists, including experts in toxicology, epidemiology, pharmacology, and behavioral scientists that were experts in driving assessment, to consider development of the list. There was agreement among the panel that a limited number of drugs generally pose a low risk to driving when taken according to approved prescribing information and when used with appropriate medical oversight. However, the panel also recognized that even among drugs generally considered safe for driving, adverse reactions may occur and interaction may occur between these medications and other drugs or alcohol that could impair driving performance. The panel was of the opinion that some specific drugs and drug classes are clearly impairing, including sedatives, hypnotics, sedating antihistamines, narcotic analgesics, hallucinogens, antipsychotics, and muscle relaxants, even at therapeutic or subtherapeutic doses. However, for many drug classes, the question of impairment falls in a gray area, either because the potential effects are highly dose-dependent or because there is heterogeneity within the class. For some of the impairing drugs in this group, it's likely that drug tolerance alone determines the extent of impairment. Examples of drugs that fall in this category include many SSRI antidepressants, anticonvulsants, and antihypertensives. There was consensus among the panel that no definitive list of safe substances could be prepared because of varying effects from dose, tolerance, drug combinations, latency between dosing and driving, and metabolic differences. However, the panel did propose a structured, standardized protocol for assessing the driving impairment risks of drugs. Specifically, they designed a tiered parallel process consisting of pharmacological, toxicological, and epidemiological reviews and a standardized behavior assessment. Applied to aviation, this would provide a more transparent and defensible approach to evaluating the suitability of all types of medication for use in aviation. Or perhaps let's not rewrite the book. Australia can be given credit for launching the first large-scale study on the use of newer antidepressant medications in commercial aviation or in commercial aviators in 1987. And based on their findings, the Australians formulated what may be considered a best practices model for treating major depressive disorder in flight crew and air traffic control personnel. During a 10-year follow-up study between 1993 and 2004, of the 481 pilots who had been permitted to use specific SSRI medications, there was no increase in accidents or mishaps that could be attributed to the use of antidepressant medications. The unfortunate thing is that in the world of professional pilots, especially coming out of the military, one of the questions that comes up with this is there any reason to believe that the incidence of the kinds of problems that would benefit from psychiatric medications occur less frequently with pilots? And of course, there's no reason to believe that it would occur with less frequency. In fact, you could make the case that it would occur with higher frequency with pilots because so many of them have been to war. It's unclear if the prevalence of major depressive disorder in aviators is similar to that found in the general population due to underreporting of symptoms by pilots. Current statistics assert that major depressive disorder has a lifetime prevalence of approximately 16% and a one-year prevalence of roughly 6%. If these numbers applied to the 620,000 holders of FAA pilot certificates, it's quite clear that there should be quite a few depressed pilots. As of today, the FAA has granted a SSRI special issuance of 70 first-class medicals and denied 230 first-class applications for the SSRI special issuance. So my question is, what kind of message is the FAA sending to pilots that want to come forward? Although the FAA initially granted 4 months of amnesty in 2010 to any pilot that had failed to report their use of SSRI medication on their medical to come forward, they no longer offer protection to pilots in exchange for transparency. On one hand, the FAA wants pilots to come forward so they can better track the care of these pilots, which is, in my mind, makes very good common sense. But without the amnesty, should a pilot that has previously omitted their use of SSRIs on their medical decide to come forward, they are thereby admitting that they had falsified their medical, which is punishable by loss of certification, and that's medical and pilot's licenses, up to 5 years in prison, and fines of up to $250,000. I fail to see how this current policy encourages pilots to come forward out of hiding to the FAA. But pilots, especially military pilots, will tell you that they are in perfect condition. They have no problems. They are the elite of the elite, the best of the best physical specimen. I mean, perfect. The myth of all pilots having, tremendous self-resiliency, wearing the proverbial S on their chest, is self-perpetuating within the industry and is unfortunately part of the mystique of being a professional pilot. Establishing a clinical practice that works solely with pilots, I realized fairly quickly that many of these guys and gals lie about everything on their medicals. They have never had an illness, ever, nothing. I mean, the joke is you don't go to your AME to, get a thorough exam. You go to the AME that's going to give you that certificate without looking too hard. The dilemma is that too often the policies between an airline and the FAA create an environment that drives the pilot in need of assistance underground. Now, the FAA has a legislative and regulatory function. They have to be able to demonstrate that they have some means of assuring that pilots are safe in the sky. Otherwise, why would we need an FAA? On one hand, they have a duty to do that. And on the other hand, it seems that it needs to be done in such a way so that pilots are supported and encouraged to be within the FAA regulations, suitability for fit to fly. And that too often the policies drive pilots to go off the grid. The highest risk situations would be for people to not get treatment at all, get treatment from unqualified people, or ignorantly treat themselves. All of these are unequivocally, without any doubt in my mind, of higher risk than having people fly while being properly treated. One of the questions I'm often asked is, well, how do you actually now work with pilots once you convince them to come in, or they convince themselves that they want to get help? What do you do with them? Well, working as a professional pilot while maintaining a clinical practice has forced me to get pretty creative with how I work with pilots, as I and my clients are often on the road at the same time. I try to work with them in person in the office if it's possible, at least for sort of an initial meeting. But often, and I would say increasingly so, that's just not a possibility as I work with pilots from all over the country and the world. Flexibility is the key. I will work via Skype. I'll work via FaceTime, Google Hangouts, any of the different types of video chat platforms have been very effective with how I work with pilots, especially since we may, be in a hotel room or be in the terminal or wherever. So again, very flexible. I maintain flexible session lengths, which is kind of a dramatic departure from the traditional 50-minute sessions. Although I would say most sessions last about an hour, but I tried to accommodate flexibility. Now, part of this is because of my working role with pilots changes. Sometimes it's therapy, sometimes it's education, sometimes it's advocacy, it's performance coaching, it's being a good representative, etc. You get the idea. In essence, I am what they need me to be at that particular time and space, and that changes. Sometimes it's maybe not what they want me to be, but it's what they need me to be, what's best for them. My professional orientation is eclectic. However, most of my formal clinical training is in working with complex traumatic stress disorders, such as attachment and dissociative disorders, and in treating phobias. I am certified in various therapeutic protocols, including EMDR, brain spotting, more recently the comprehensive resource model, which are all neuropsychological treatment methods for working with trauma. However, I very rarely utilize them when working with pilots. With pilots, I usually end up utilizing cognitive behavioral, psychodynamic, interpersonal therapeutic techniques, and neuro-linguistic programming. As I've gained experience working therapeutically with pilots, I adopted the philosophy of using whatever works. Regardless of the therapeutic technique, I make sure that the process is largely and very collaborative. I cannot understate this enough. Pilots need to have the yoke in their hands. They need to steer the ship. Collaboration is a natural fit with pilots, as it closely mirrors good CRM. One particular model I've studied and utilized extensively when working with pilots is from a brilliant former Royal Air Force wing commander who's a professor and psychiatrist named Dr. Gordon Turnbull, definitely a big influence of mine. Dr. Turnbull did a lot of trauma work in the aftermath of the Lockerbie air disaster in 1988, before CISM and CIRP protocols were even around. He also did quite a bit of work during the Gulf War of 1991 and with Royal Air Force mountain rescue teams. His model is called the stress model, and although I've adapted it over the years to fit my own style, it really laid the groundwork for one of the primary ways I conceptualize and work with pilots. What's important here is that I don't approach the work that I do with pilots as a one-size-fits-all approach. Each pilot has their own special kind of needs. And although there are themes that I see, certainly there are commonalities of problems that we as pilots experience. Each pilot has their own experience, and what's important to them may not be something that's important to the next pilot. And so I really try to honor what is important to them, what they're working on, and where they need to be, making sure that I give them exactly what they need. I also, because as pilots, we're very results-oriented, I work with a very sort of results-oriented orientation, because the objective oftentimes is, how do I get back to work quickly? Because I need to work, I need to support my family, I can't take a lot of time off. How do we do this? So I really try to guarantee results. Long-term psychotherapy is often not in the cards with a lot of the clients that I see. And so the orientation of performance coaching is sometimes something that I have to utilize with these pilots, and it fits very well with my orientation and how I approach things. So again, flexibility, transparency, and being very, very collaborative is what I find is most successful with the pilots that I serve. So to answer the question, doesn't our EAP already do that? I would have to say that in my own personal experience of the pilots that come in and of my experience of EAPs, I would have to say no. And so the question I would ask you is, what are your thoughts? What do you think? So this concludes the talk. I hope that you got something out of it. I hope that maybe it sparked some thoughts and ideas and consideration in you, and I would absolutely love to hear from you. So if you have any thoughts or questions, please don't hesitate to reach out and contact me. You can contact me via email, matt@liftaffect, LIFTAFFECT.com, or you can call me. My office number, 303-808-4617, or you can even try my cell phone, area code 917-402-4640. Reach out. Let me know. Let's start the dialogue. I think that what's important is that we're talking. It's important that these issues that affect this community, my community, our community, are being addressed, because I think they've been pushed underground for a long time, and the jury's out. We know that that's not helpful, and it doesn't give us the progress. It doesn't get us to the results that we're looking for. So appreciate your time, and I hope to hear from you.